Okay, it's 4 o'clock, exactly, so we're going to get started. This is the Hot Topics session. We have a very exciting panel of speakers that are going to be presenting today. First thing I want to do is thank Mark Mullins, who's sitting there in the second row. He organized this. He is the incoming president of the APDR, and he's done a great job in the meeting so far, and I think you'll all find this very exciting. So, nice round of applause for Mark. We have co-moderators here. The co-moderator is Dr. Juliana Bueno, who's the Associate Program Director at University of Virginia. She's an assistant professor of cardiothoracic imaging, and she's going to be introducing each of the speakers. There's 7 speakers. I asked them to keep their remarks relatively brief, to 10 to 12 minutes, to leave a lot of time for Q&A. So, Juliana, take it away.
Thank you so much. Our first speaker today, Dr. Anna Rozenshtein. She's an associate professor, director of the cardiothoracic imaging section at Westchester Medical Center, and she's going to give us an update on the match. Thank you.
Oh, yeah.
Select your session. We are at 4. Lovely. I managed. Starting. I'm a New Yorker. I will speak very fast. I'm timed to 15 minutes. I only have 12, so we're going to race. And thank you for being here on this gorgeous day instead of staying at the pool. I'd like to thank my committee members. I represent the Matching Plan Committee. They worked very hard the entire year. Hopefully, you will find this information useful. I also would like to thank the APDR staff, the invaluable staff who helps us every day, particularly Joan, thank you, if you're here. So what do we do? The Matching Plan Committee, we look at data. We look at real-time ERAS reports, which are useful to you because they really tell you what's going to happen in the match, and ERAS publishes them monthly. After the match happens, we also look at yearly NRMP reports. We look at radiology performance in the match as a specialty. We compare it to the archival data, hopefully to discover trends that may help us in the future. So I will quickly present you the match results in comparison to other specialties. I'll tell you about something that you know already, the ERAS over-application problem, and I will give you the results of the Focused Early Discovery and IR Applicant Advisory Survey, which a lot of you, in fact, participated. We just closed the survey last week. So overall, radiology has grown. We now have 1,235 positions. This growth of 20 positions came from a little bit from DR, 9 positions, and 11 from IR. So we are growing. We have more applications this year. We're not back to the very competitive year of 2009, but we have grown. We have a record number of applications per program, which may or may not be a good thing. I'd like to talk to you about the monthly ERAS updates. So the data that we get from the NRMP is the retrospective data. Something has already happened. But every month after the start of the season, ERAS publishes updates. They are on just Google ERAS statistics, and they're there. And the question is, can we use that data, the data on the applicant pool and the number of applications per applicant and number of applications per program? And so we looked at 21 years of the entire data for the entire existence of ERAS. And we found a very strong negative correlation between the size of the pool, how many applicants we have, and the number of unfilled positions, which is our performance in the match, and the number of ranks per applicant, meaning basically the length of the required rank list to fill, which is basically your cost. So, you can actually, we conclude that, it's been like that for 21 years. So we conclude that you can use that data as it is coming out. In fact, we used comparison for November because we felt that this was a very, very useful match, months kind of in the middle. So we conclude that it is useful, and these conclusions are going to be published in academic radiology. So you'll see them hopefully this summer or in the fall. So as predicted by increase in the number of applicants, we have fewer unfilled positions, only 10 this year. And that the cost of doing business, the number of applicants per position that you need to rank on average has fallen Okay, so that's good. That was for DR. IR shows somewhat volatile picture, but they've only been in the match for 3 years. They have very small number of programs, and therefore, really not too many conclusions can be made from that. We'll just await further data. However, the ultimate measure of our competitiveness is how many of our positions are filled by US medical students. And here we're fairly stagnant. IR is doing very well this year. They completely filled with US medical students, and we are sort of treading water. In comparison to other specialties, very cold comfort, we are somewhat better than anesthesiology. But the rest of the competitive specialties are ahead of us, and that is actually quite important. In a moment, you'll see why. So if you are looking at ERAS and NRMP data as we do, you're going to see a striking difference in the number of people, applicants, we're talking about US medical students right now, who apply, and the ones that are ranking us. So somewhere between application and the rank list, we managed to lose approximately third, 460 of our applicants. And the question is why? So if you look at this attrition rate over the years, it is stable in spite of marked variation in our pool, in the quality of our applicants, in our USMLE scores. And this means that it's not we are filtering them out, but they are probably using us as backup. You know, they're applying, but they're not ranking us. And so if you actually look at what happens, these are the applicants who rank, and these are the applicants who match. For a fairly long period of time, that's very close together. So if you apply, you're likely to match if you're a US medical student. Exceptions are here. That's a very competitive year. That's 2009, when 91% of all positions are filled by US medical students. Okay? Now the situation is different. We are diverging again, and we're starting to diverge more and more. And now, you know, only 72% of our positions are filled with US medical students, which to us means that the situation has changed, that the DR is probably being used as a backup specialty. Crossover ERAS data confirms it. Just ERAS statistics, all of you probably have seen it. In this past year, 690 of our applicants applied to more competitive specialties, which means that they used us as backup. When you open your ERAS mail box and you see this, you know, wealth of applications, please keep in mind that, you know, 68 of them will rank diagnostic radiologists statistically, you know, and 52 will match. Just so that you know what you're dealing with. Even though you're seeing more applicants in your boxes, that is not necessarily a very healthy sign. All right, just to show you that DR is now used, 24% of all our US medical students are using us as backup, as not their first choice. In IR, it's actually bigger, it's 28%. And I'm nostalgic to 2014 when I stood here and I said, you know, yeah, we have fewer applicants, things are getting tighter, but at the very least, our applicants are committed. Because at that point, we were just like dermatology. We were 3% or 4% of them chose us as not their first choice. Anyway, so we have more applicants, but do they really want to match? Not necessarily. And yet, they sent 50 applications per person. And this has been growing steadily, as you can see, over the course of 21 years. Please don't imagine that we are terribly off. In fact, we're not as badly off as ortho, radonc, urology, and dermatology, who are pushing 60, 70, 80 applications per person. And it has gotten so bad that ENT is loudly calling, in their literature, they're calling for an ERAS cap, which for us may not be a very good idea. So they're proposing aggressive advising. That's pretty naive, because people who are advising them, deans of students, right, are really not going to advise them to, cut down. They are proposing supplemental program-specific essay, which is probably impractical in the days of cut and paste. And they're calling for a cap, and the cap is a bad thing because they're not capping all specialties, right? So they're going to just spill over into backup specialties, and that is becoming us. All right, so how much more time do I have? Just so that. 5 more minutes, great, fabulous. Okay, so we could actually get rid of the rate limiting step, right? We could just jettison the interview. That's heretical, all right? Okay. I personally believe in it, but very few of you will, right? So anyway, so there is another solution. It was pioneered by Alvin Roth, who is a Nobel Prize-winning economist, in fact, for the match of 2015. And so they basically asked themselves the question, why does this happen? And this happens because applicants in all entry-level markets over-apply to enter the market and see how competitive they are. They cast a very wide net to discover how many interviews they get, and their subsequent strategy depends on it. And what do? We're trying to discover their true intentions. And so Alvin Ross and company tried a completely different approach in the market for graduating economics PhDs. What they did, they constrained the market in the beginning. They said, why don't you just apply in the first months, there was a big conference, to 2 or 3 institutions. I think it was, something like that. And they rapidly decreased congestion in the market because a lot of the applicants simply, sort of found their way to where they belonged. And so we thought, why don't we try the same thing? Why not constrain our ERAS for 2 weeks to 10 applications, right? So the applicants would get out of it our almost immediate response, and participating programs would guarantee response in 2 weeks, yes or no, to interview invitations. So this is likely to work for all of us, and we asked your opinion. We just sent a survey, we just closed, of the entire membership. 106 of you responded, so your response rate was 34%, which is average for us. It's not bad. 75% of you said that over-application is a problem. 71% said that you would like to try the discovery period pilot. And 94% of you said, 2 weeks is probably enough. And so the APDR, as a response to your survey, as a response to your response, the APDR is forming a match task force. And we're going to look at this in depth, and please stay tuned. We will tell you what you find. And the second part of that survey was the question of advising IR applicants. We have enormous variability in this new competitive specialty advising. We asked, if you participate in DR recruitment, does it matter to you that a candidate decided to apply to both IR and DR in your institution? And 22% of you, if you participate in DR recruitment, said, yes, it matters to us, and we will penalize the applicant. On the other side, we asked, if you participate in the IR recruitment, does it matter to you? The same thing. And 10% of you said, yes, it does matter to you. Right? So we know that a proportion, about a fifth of DR program directors will penalize the applicant for applying into 2 places. This is really a unique specialty, not in primary care, but specialty, which has 2 pathways like that. And we would suggest that you make it clear to the applicants as they are looking at your website whether or not you want them to apply to both. That would be pretty fair. So in conclusion, okay, things are looking up. We have more training positions, DR is continuing to recover, IR is doing well, and early ERAS data is reliable. You will see that in academic radiology, hopefully before the next match season for details. However, US medical students are increasingly using radiology as backup. ERAS over-application is a problem, and we are working on it at least to propose a solution. And some of our directors will penalize double applications, and therefore we are suggesting that you be upfront and clear and transparent to the applicants about it. Thank you.
Our next speaker, Dr. Edward Bluth. He's a chairman emeritus of the radiology department at Ochsner Health System in New Orleans, and he's going to give us an update of the job market. Thank you. You can just stay here.
Thank you very much, and I appreciate the opportunity to present this information. And I do quickly want to thank all the members of the Human Resources Commission who've helped in the work that we've been doing over the last 6 years. I'm going to give you the top 10 insights in a very quick manner that we gained from all the 6 years that I've been presenting to this group, and we've been collecting this information through the ACR. The first major insight is the number of groups in radiology is decreasing. We started with around 1,900 to 2,000 groups, and we're down to around 1,800, and I suspect it's continuing to decrease as we see mergers, consolidations, and buyouts of practices, as well as, to be honest, some improvements in the ACR database. But I think really we're actually seeing a true phenomenon of consolidations, and people need to be aware of that. The second insight is the percentage of practicing radiologists by age remains stable and is unchanged in the past 6 or 7 years. So that, as you could see here, this is the 6-year data. And if you can look here to specifically reading it, you'll see that there are around 2,000 radiologists over the age of 65 who are practicing, and around 3,400 who are younger than the 36 who are practicing. So it sort of balances out. And we have 6,400 who are between the ages of 55 and 64. So in that group, over the age of 65, we have close to 10,000 radiologists. Gender has not changed in the number of years we've been following this. It's around 20 to 22%. It's increasing, however. There is an increase in percentage of women in radiology as we look at ages. So the younger ages, there's a higher degree of match in residency and a high degree of practicing radiologists. The current workforce is relatively stable when we compare by subspecialty, when we compare 2016 to 2017, but has changed dramatically since we began the survey. As you could see here, the largest percentage of subspecialties which we practice includes body imaging, which is the number one at 14%, general IR 13%, neuroradiology around 12.5%, and then general radiology around 10%. And if we compare over the 6 years, the biggest, most dramatic change is in general radiology. When we started the survey, there were 32% of radiologists who were practicing general radiology. Now it's down to 10%. And this is probably the result of retirements and reclassification of individuals. But I think that's a dramatic change. We've seen increases in body imaging and in IR, but they're not yet statistically significant. But that's the trend of an increase. A significant number of mid-levels are currently supervised by radiologists and working in radiology. There's been some recent controversy in some of the web links related to radiology, and I wanted to make sure that you understand that there are presently nearly 20 to probably 2,500 at this point mid-levels practicing within the field. There are around between 31,000 and 34,000 radiologists practicing. So it gives you an idea, but they're increasing in number. Not RAs dramatically, but nurse practitioners and PAs. And just a word of warning, the only group that we have anything to do with the scope of practice is RAs. So the criticism and concerns about RAs in radiology is probably inappropriate. You should be perhaps more concerned with the increasing number of nurse practitioners and PAs who potentially can have an independent scope of practice and potentially, if their individual accrediting agencies wanted, could independently even interpret, not RAs. So realize there's a significant difference. The outlook for jobs, which most of you wanted to come for and hear about, is good. And that relates to, I think, probably the increase in number of resident applicants. In 2017, we hired between 1,600 and 2,000 radiologists. Remember, there were 1,200 finishing residences we just heard, so there were a number of jobs for that. In 2018, the expectation is It will be better than that. That'll be around 15% increase. Will be between 1,800 and 2,300 radiologists. And the results, the actual results of the 2018 survey will be presented in 2 weeks at the ACR annual meeting, and you'll hear it specifically at that point from Claire Bender. If we look, though, at the change, and there is a dramatic change in this subset, the newest group that is significantly represented is the after-hours radiologist. 12% of the new hires are being looked for in that area. This is very different than the makeup of the radiology workforce when I started, certainly, and even 6 years ago. That wasn't even a representative number. Now it's very, many groups are looking for those individuals. If we look at who is taking jobs, around half of them are new graduates, and the other half are people changing jobs and there are now opportunities for those individuals who had to take a job in the around 3 to 4 years ago when the job market was very tight and had to take any job that was available. Now there are more open jobs available in many different areas. So people are changing, but there is no question, and this is particularly for all potential graduates, people enrolled in radiology programs. Virtually everyone wants to hire radiologists who have fellowships. Even though there are more jobs, it's your security to have a fellowship. And that includes those who are taking their first job as well as changing jobs. Most people want to hire fellowship-trained radiologists. And this is the slide to remember: jobs are increasing. And the profile looks good for the next few years, but don't be disappointed. It is cyclical, and it may happen again. So I'm glad that I've lived long enough to see the cycle increase, because I felt I was responsible solely for the decrease in applicants to the radiology residency programs by starting the survey. A piece of information for people who read the literature and a lot of the papers we've written from the HR Commission is that the 3-year projections are inaccurate. They're underestimates. So don't look at those projections and say bad news is coming in 2 or 3 years, because they're inaccurate. But what it can be used for, and the reason we continue to collect the information, it can tell you the subspecialties. The chairs of the departments have no idea, or heads of groups have no idea who they're going to hire in 3 years, but they have an idea of the kind of specialty they want. And it's the same that we're presently hiring. The top 3 are body imagers, after-hours radiologists, interventional radiologists, and breast imagers. Those are the top 3 to 4. Also, another major trend is an increase in radiologists working part-time. Most groups have part-time radiologists, but we've noted in the period of time we've collected this information that the groups the part-time workers have increased to around 16%, and probably more in this coming year. If you look at those people who are working part-time by age, it's not a surprise that there are more people working part-time who are older. But if we look at the information by gender, we'll see that overall, 16% of radiologists work part-time, but 30% of women radiologists work part-time. So there's a statistically significant difference between men and women in the interest in working part-time. If we look at those working full-time by gender, there really is no difference between the makeup of the radiology force and men and women. But if we look at those who are working part-time, we see a dramatic difference, particularly in the lower and younger age groups. So it's a demographic and a change in trend that we all need to be aware of as we're planning and planning for the future of our department. If we look at people who have gone from full-time to part-time, we see that it goes around 18 to 19% convert every year from part-time to full-time. If we look at those who are going from part-time to full-time, it is very small. So people who are, maybe as children are out of the homes, are not coming back. Once they've seen the pasture there, they're not coming back into the barn, shall we say. And if the trend of increasing part-time radiologists continues, and we are successful in trying to attract more women into radiology, we may actually have a shortage of radiologists and may need to consider increasing the size of residency and fellowship programs to increase the number of radiologists and to achieve the access that we need to achieve. The ninth major insight is we need to follow retirement trends. 25% of practices reported that a radiologist is retired, and that's around 500 radiologists retiring every year. And as you could see, it isn't only those over the age of 65. A large number of radiologists over the age of 56 to 65 are retiring every year. So we need to follow that and determine what is going to happen with that group. And the last trend is, I don't have time to discuss, but we will be publishing articles about the prevalence of medical illnesses related to the radiology community. And we all have a vested interest in becoming aware of that, the issues that are affecting us. So in conclusion, jobs are more plentiful. And I repeat that, jobs are more plentiful. There is concern, however, that with burnout increasing, and this meeting has highlighted that, retirements may also increase because there are a lot of people who are over over the retirement age and still working and even financially capable of retiring. If the trend of increased part-time work continues, we also may lead to a need for increased number of radiologists. We obviously need, therefore, to monitor the workforce closely to determine if we need to increase training slots. And that's something I think it's very important for program directors to be aware of and to consider. And the other thing, alternatively, the efficiency is achieved by AI may not be as great a threat to radiologists and us especially as some have considered and speak about. So actually, the issue of AI efficiency actually may help balance the workforce, and maybe we don't need to increase the number of training slots. We just need to take into consideration the fact that AI will make us more efficient. So with that, actually, I managed in this short period of time to give you the top 10 insights in the radiology workforce. Thank you very much.
Thank you so much, Dr. Bluth. Our next speaker, Dr. Jonathan Swanson. He's a pediatric radiologist, associate professor at the University of Washington, and he's going to present the results of the APDR survey. Thank you so much.
It is always nice to go after someone who says that there's more jobs in the market. It softens up the audience, I think. My name is Jonathan Swanson. I am Associate Program Director at the University of Washington. I'm also the co-chair of the APDR annual survey along with Dr. Paladin. This survey came together, was edited and analyzed by a very active group of committee members listed here, and was also put together in conjunction with the RSNA survey group. And as you may remember, it came to you back in November. There were 52 questions. Of those, most of them were multiple choice. 5 of them were free text. We sent it out to 319 active members of the APDR, and 116 of you responded for a 36% rate, which is about what we get. If you didn't respond this last year, the great thing is you're going to have another chance to respond in the upcoming survey, so thank you in advance. Those who responded reflect the overall demographics of the APDR when it comes to the program type, the program size, and the program location. If you blow up one of these categories, for example, program size over time, and look at who responds to the survey going from 2001 to 2017, the one trend that I will point out here, this is program size over time. The blue line is the 12 or less residents in a program. That has decreased over time, in many cases because as radiology has increased numbers, those programs have moved from the very small to the small to medium category. We're going to look at a number of different themes that we probed in the survey this year. The first one is program director support. In particular, how many assistant or associate program directors do you have? The survey response said that 91% of the programs had at least one associate program director, and 40% had more than one. Not only that those associate program directors, 58% of them had protected time to contribute to running the program. So how has that changed over time? If you compare it to 2002 and now 2017, in every category, presence of an associate program director, having more than one associate program director, and having protected time for that associate program director, all of that has increased when you make that comparison. There is one caveat, and that is with the protected time. 64% of the time, that protected time that goes to the associate program director is pulled from the existing protected time that had been provided to the program director. So it is the same size pie with one more slice in it. When you look at the range of how much protected time associate program directors get for the people that responded to the survey, it goes anywhere from less than 0.1 to greater than 0.4. If you then look at the range of how much time programs give both their program director and their associate program directors in total, the range is from 0 to 1.6. Clearly, if you went to the RRC, 0 is no longer a proper answer, but there are some programs that get greater than 1.6 FTEs, and congratulations to those programs. Which of the following activities do the associate program directors do? They do a lot. The top 5 included the CCC, resident recruitment, semi-annual evaluations, annual program evaluations, and curriculum development. If you look at the CCC specifically, the APD serves as the clinical chair 48% of the time. Is your APD a member of the APDR? 19% of you answered no. The membership committee would like to talk to you at the end of this meeting today. Resident call, this is always a hot topic. When you ask the question, do you think residents benefit from independent call, 95% of you said yes. And then if you ask the question, does your institution allow for independent call, 69% of you answered yes. So this is going to be questions that we continue to ask from a year-to-year basis to see how this trend and if that discrepancy continues to widen, given that there is a continued pressure for 24/7 call by attendings. Do you have an on-call assistant to answer phones or do other administrative tasks for the residents on call? 24% of us do. For those who don't, 40% of them don't because they have enough hands on deck, either because they've got attending or multiple residents. But of the 60% that don't, it's not because they don't need it, it's just because they don't have the funds. So where do the funds come from for those who do have on-call assistants? 75% of the time it comes from the department, 25% of the time it comes from the hospital. Fellowship match. If there's a hotter topic than this, I don't know what that is. When we asked this question back in November, so this is the caveat, we asked it in November, and this is not the same question that you received in the last couple of weeks from SCARD, but when we asked the question of, do you support having a unified fellowship match for all radiology fellowships, 80% of you support that. So somewhat unified in your answer. When we then ask when the interview should be and when the match should be, again, in November, and I think the signal may be stronger in one way or the other now with the SCARD data, but when we ask in November, it was a hot mess. It was somewhere in your 3rd or 4th year, and I've heard over the last couple of days really good explanations for each one of these slots, both for interviewing and for the match. The interviewing time is up top, the match is the bar below, and I am very excited to see how this pans out. 4th year engagement. As you know, we've moved the core exam into the 3rd year. If you move the core exam to the 3rd year, the question was, does it make the 4th year residents less engaged? When it comes to clinical activity, when we ask program directors, those residents are still moderately to significantly engaged in their clinical activity. If you change the question a little bit and say, what's their attitude toward learning, you get a new bar called checked out and not engaged, and that's about 30%. Which of the following best represents the research activity engagement? When asked that, it's somewhere between moderately and minimally engaged in your 4th year. When you ask about teaching engagement, moderately engaged, I think would best sum up this bar graph. Mini fellowships are provided in 80% of the people that were surveyed or in their programs. And then when asked whether or not the mini fellowships have been successful, 2/3 said yes and 1/3 said no. For those who said no, they mentioned either not having the bandwidth to offer many fellowships, not getting the buy-in from residents to act like fellows, or not having a formal certification process. IR residency. When we asked in November if you had or planned to have an IR residency, 71% of you said yes. If you were planning to utilize the independent pathway, 55% they were planning to heavily utilize the independent pathway, and 35% thought sporadically and to use it to fill in gaps. Because the IR integrated residency is highly sought after right now, we asked what criteria would those who are evaluating the candidates use, and this was a text response. So in trying to sum up the many text responses, some themes that came through would be looking for applicants who had a strong level of understanding in their interest in IR, applicants who were either internal candidates or who had rotated in the department prior to applying, and then the traditional things such as test scores, grades, leadership, and volunteer experiences. One thing to note is that interview performance only showed up 16% of the answers. Do you participate? If we say that exposure to IR and insight to IR is important, how are we teaching our medical students about IR and what are the different venues that we're using? The most common is the IR electives. Other alternatives include an interest group and then also having IR faculty doing the education to the younger medical students. Asking if the DR programs are losing funding to fund the IR program, the answer is, in most cases, yes. 25% they're not, but in the rest of the cases, up to 4 spots were lost for IR funding. That being said, if a resident is in the integrated pathway and says, actually, no, I want to go back to DR in their 4th year, 85% of us will gladly take you back. So some miscellaneous questions. For the CPT codes, the case log submissions, we asked how accurate do you think your case log submissions are? And 40% of you thought they were very accurate. The rest of us had some skepticism about the accuracy of our case logs that we're submitting. We also asked about moonlighting. Do we allow moonlighting? And then 88% of the people that responded say that programs do allow moonlighting, and then went on to say, what type of moonlighting do you allow? And it's, in 50% of the time, both internal and external moonlighting. So some themes that I want you to take away from this. There are more associate program directors helping the program directors, but that with the caveat that some of that time is coming from time that had already been allotted to the program director. Independent call is valuable, but it is not available to all residents, and that's a continued pressure that we're going to monitor with our survey. There is a call to unify a fellowship match, and then there is some disagreement about when that should happen. Case logs can be somewhat inaccurate, and the DR programs are losing spots to the integrated programs, but we are willing to take those disgruntled IRDR residents back. So if you have great questions that you'd like to have in the survey, please reach out to me, and my information is in the directory for this upcoming survey. And when it comes into your email box, I appreciate if you'll fill it out. We always appreciate your input. Thank you.
Thank you so much, Dr. Swanson, for that summary. Our next speaker, Dr. Seth Stalcup. He's an assistant, it's Dr. Cory Pfeifer. He's an assistant professor, neuroradiologist at UT Southwestern in Dallas, and he's going to address the challenge scenario of a resident who fails the core exam. Thank you so much.
Thank you. Okay, so this will be a little bit less scientific. As you can imagine, not too many people want to come forward and talk about core exam failure. So what I did have is a discussion with about 30 different residents who did fail the core at some time in the last 3 years, some from the internet, some in person, some through contacts. And I told him, I'm going to speak at AUR this year, and I want you to tell me what you would like me to tell program directors. So a lot of this is going to be basically, from them, and I'll give you a couple of scenarios of some incidents that I hope you'll find useful. So here's a letter from a resident, and you can see some of the stages of the Kubler-Ross grief construct, if you will. Shock and anger, some bargaining, denial. This last part here, all that's running through my head at this point is that this may somehow prevent me from getting a job, or that it'll forever label me as some sort of subpar resident. And that's what kills me the most, given this program's track record of passing boards. And I know that a lot of programs who'd had, they were very successful on the old exam when the first core came out, they had a little bit of a step in some places. I know one program had 5 out of 6 fail the first year, even though they hadn't failed an oral exam in the prior 8. All right, so you know most of this already, about 87% pass. You may ask yourself, is that a fair number? Many residents ask that question. 3 years ago, I did a survey of about 230 board exams, all specialties. Okay, so all medical specialties. And of those 230, I'll give you a hint. What was the pass rate? It was 87%. So I don't think it's a coincidence if other people think that's not fair. It's true throughout medicine in general. So anyhow, a couple of other things. They don't publish the second time. If you take it the second time, what your pass rate is. It's about 50% based on resident reports. I don't think this is true anymore, where smaller programs and community programs were having difficulty. This seems to be normalizing overall. One thing I will point out is that even though there aren't as many U.S. medical students who are matching, the Step 1 average is still 7th over all of those participating in the NRMP. And yes, I get it, it was number 2 back in 2006. But the residents who are matching into radiology are still very smart people, okay? There are a lot of specialties who would love to have the board scores that radiology programs get. Okay, so in the short term, who suffers the most is typically the resident, right? Shame is a huge thing. And I think that this is, what they worry about. Just like I told you, that quote from that resident I shared from you a minute ago. I'm worried that I will be a subpar resident. I'm worried that I will have this albatross around my neck, that I'm the one who's going to bring the reputation of this program down. In reality, most of them I talked to, about half of them passed it the next time. Eventually, they basically, for the most part, passed it. I don't have data on everyone, obviously. But, you do a fellowship, if need be, and you go on and take the certifying exam, and it doesn't hurt you because the certifying exam is so far, past the core exam. However, as Jim Anderson talked about earlier, these metrics are collected for your program, and different programs have different reputations and so on. So you don't want that, dead cat in the trash can, somebody talking about on the internet forums. So in the long run, I think that the program is probably more impacted. So, root cause analysis. I'm sure you all do these as part of your program evaluation committees. Look at your trends. We've had the core for many years now, so I'm sure that you know what works and what doesn't work for you. Hopefully, anyway. I hear different reports on that. But the one thing to point out is that the plural of anecdote is not data. Okay? So if you have 1 or 2 failures and you're still above that rate, you probably don't really need to make a whole lot of changes to your program per se. But what I do want to talk about are some interpersonal factors. And one in particular that comes is something, the setup to fail syndrome, which I first read about in the Harvard Business Review a little bit while ago. And I'm applying one particular resident to this theorem, and we'll just go through the steps of it. So the new resident starts, and he's doing well, and the program director is happy. Okay? This is Frank Martin, former K-State basketball coach. All right, and then there's a triggering event. All right, the resident performs poorly on the in-training exam, so 5th percentile here. Right? Program director is not happy. He signs some additional reading assignments, threatened with probation. So one thing about probation, as you all know, you fill out a medical license application, you fill out credentialing, what have you. You have to record that. This is a permanent stain. Okay, so what happens is the resident goes into this mode of self-protection. They start looking at old in-training questions. They try to work the system, try to find a way to not have another bad outcome on their in-training tests, because they want to avoid that probation at all costs or ousted from the program. I do know one resident who was actually dismissed 3 months before graduating after he failed the core exam. Anyhow, his call improves his medical knowledge, so he does a little bit better. However, up to the 50th percentile, however, the program director says, whoo, I was worried. Not a lot of confidence. So again, the resident goes back and goes back to the self-study and has some, personal problems, has an exam glitch. Not that that's ever happened, right? And then, of course, you get this. And in the particular case that I'm talking about, this resident was like in the 42nd percentile on in-training shortly before the core exam. So take that for what it's worth. So some predisposing factors, is he a good test taker? Obviously, the written test is a lot different compared to the oral test. Are they seeing all the diseases they need to see on a day-to-day basis? So I'm now faculty at one of the largest programs in the country. I'm a graduate of one of the smallest. In the middle, I worked with a lot of residents from 3 or 4 different medium-sized programs. The experience is quite different, and the approach that each program has to take is going to have to be tailored to the experiences that you have had personally, and then adjust with differences in the types of applicants that come into your programs and so on and so forth. Personal difficulties, as we can see from the last slide. All right, so core exam recalls. They're about like, North Texas barbecue. It's not very hard to find, but highly variable in quality. I will say that I never met a resident who said, geez, I wish I had more recalls. It doesn't seem to be, over the past few cycles, didn't seem to play into much of an effect regarding the test. I certainly hope that improves, or that continues to be the case, I should say. All right, one thing to mention, not all residents are the same. 10 years ago, what you did with a resident may not be the same as you do today. And even residents within the same class may have different priorities. And the one thing that residents told me who had failed was that they just wanted their program director to talk to them and say, this is what I need, this is what works for me. Whether it be a difference in the call, maybe they want more call. Maybe they want different opportunities or anything. And no 2 residents are alike, so it's not a catch-all solution. Please don't do this. Interestingly, this is the basketball coach before Frank Martin at K-State, appropriately named Huggins. But anyway, just the point of this slide, make sure that the resident is okay. I can't emphasize that enough, all right? That first letter I showed you, immediately I'm told was met with a letter from the chief and the program director, hey man, it can happen to all of us, we'll get them next time, we'll do better. Because this affects residents deeply. And you need to make sure that they are taken care of and that they're okay when this happens. I borrow this a little bit from a talk that Richard Gunderman did a couple years ago in the great basketball coach John Wooden. And there's something about John Wooden in that he had about 180 plus basketball players play for him. And toward the end of his life, he had a very long life, but his old team members would come to him, visit him in his home, and he knew all of their children's names. Now, I'm not saying that you need to do that to be an effective teacher, but I think that really helped him as a coach to be able to deal with his personnel on a personal level. Incidentally, I know before I came here, I talked to residents from programs of the last 3 A-cubed outstanding teachers, and I think they all told me the same thing. When it comes to what they really thought was great about that teacher, that program director that they had, it was that they felt like they could communicate with them. As an epilogue, the resident who wrote that letter that I started with at the beginning he's a private practice radiologist, and he's doing well.
Thank you so much, Dr. Pfeifer. Our next speaker, Dr. Seth Stalcup. He's an assistant professor, neuroradiologist, and he's also assistant program director of diagnostic radiology at MUSC. He will address global health in radiology.
All right, thank you. I'm glad this is considered a hot topic. It's something that's very near and dear to me, so thank you, Dr. Mullins, for the invitation. And for those of you who saw, Dr. Sekar gave an excellent talk yesterday on this subject, so I'll try and build on some of the themes that she covered. I have no conflicts of interest. The first question people often ask when I bring this up is why bother? There's plenty of need here in the U.S. I practice in South Carolina. There's a lot of poverty, health access disparities, plenty of things that we can address here in the U.S., and that's true. But the burden of disease is much higher, and the access to care is much lower in the developing world on orders of magnitude. We send our residents to Uganda to a clinic, and there's outreach clinics around that site. And when patients hear that an outreach clinic is coming somewhere close by to them, they'll walk a day or two and sleep on the ground overnight just to make sure that they're seen. And we're very fortunate that level of need doesn't really exist in our country. And radiology has kind of been late to the game. Many programs have been doing this for decades, but a survey from several years ago, less than 10% of radiology residents had global health experiences during training, and that was the lowest of all specialties surveyed. It's because we're resource intensive, and we just weren't available in the developing world, but thankfully that's changing. Imaging is spreading throughout the world. Ultrasound is certainly kind of the first wave, with X-ray not far behind, but CT and MRI are going to follow. And that just means there's a ton of potential partner institutions out there who are acquiring imaging for the first time, and this is really a golden opportunity for us and for our trainees to get involved. And if we don't do it, then other people will. There's no way this technology is not going to continue to spread. And so if we're not going to be involved and show our value of medical imagers and show our knowledge of medical imaging, then the surgeons and the infectious disease docs that are already there are going to be the ones implementing the imaging. And just selfishly, it's a great tool for recruitment. As the assistant program director, we do an overview of our program each morning before we interview applicants. And we have one single slide on one potential elective they could potentially do in their senior residents, and that's by far the thing they ask me about the most. The med students are excited about it, they're really enthusiastic, and so it's been really great for us. And here's our senior resident giving some education in Uganda. So assuming I've convinced those of you out there who are on the fence to get started, the very first thing you need to do is make sure you're not the only one who's really excited about it. If you start talking and everyone kind of averts their eyes and shrugs their shoulders, then just go volunteer on your own. It's a great opportunity for you just as an individual. But if you want to create a program, you're going to need help. You just can't do it by yourself. You need both help from your faculty as well as your trainees, because that bright-eyed medical student who's really enthusiastic to go, by the time they're PGY5, they're married, they have kids, they have a house. They can't just pack up and leave to Africa or South America necessarily. So you need a high level of trainee interest to make it sustainable. And you must have support from your department chair. As rewarding as this experience can be, it costs money and it does not generate any revenue. So you need to make sure that support's in place. And once you have that support, then you need to decide, are we going to kind of strike out on our own and develop something here, or are we going to partner with an existing program? As Dr. Sekar mentioned, RAD-AID has a lot of longitudinal things you can just send your residents they can volunteer for directly through RAD-AID. But another helpful resource is that there's a list of programs out there that have RAD-AID chapters. There's a list of training programs that are involved in global health. So you can see what other people are doing, where they're sending their trainees, reach out to them for guidance. The ACR also has an international outreach program. There's a scholarship available for trainees to help offset the costs. And then APDR and AUR. There were so many people in this room that are currently involved in global health that really helped us out. They helped us problem solve and troubleshoot and get our program off the ground. So just use this opportunity to ask around, find people who are doing it, and they're just a phenomenal resource. If you want to do it so your resident gets credit through the ABR, there's some bureaucracy you have to deal with, but it's not overly burdensome. The first thing is to draft a letter of agreement between your international institution, your local GME, and then identify supervising faculty. And that was a little challenging for us because where we send our trainees, there's no trained radiologists. So it's not really feasible for our faculty to stay with them the entire time. But we had to identify someone who would supervise our trainee. They're still in training, whether they're here or abroad. They need supervision. And that person who is in charge must have significant experience and education, acceptable to both MUSC in my case, but also to the ABR. So thankfully, the medical director of that clinic had a ton of experience with different specialties coming in. He had overseen a lot of trainees, and so he was able to serve as our supervising faculty when our radiologists were not present. And then just as you would for any other rotation, you need structured learning objectives, the goals for the resident, and a way to evaluate their performance when they're done. I'm going to put a plug in for data sharing. There's no substitute for being present. Here's our senior resident verifying chest tube placement with ultrasound, and here's the local physician and the medical imager. So you can't replace that experience of being present and working face-to-face with your international collaborators, but it's just not feasible to have someone there year-round. So if you use data sharing and image sharing, you can, right from the comfort of your own home or office, help them with challenging cases. You can teleconference in if they have a training program of their own. You can teleconference in to your noon lectures. And this really expands your impact. It moves you away from a medical mission where you kind of helicopter in, deliver some care, and then helicopter back out. Now you're really a remote consultant for your partner institution. It really builds those bonds. Like I said, you can be a resource, and if you just think how many resources we have in this country, StatDX, all of our subspecialty trained colleagues, all the medical literature we have available at our fingertips, that just doesn't really exist. So in a really challenging case, our resources can be invaluable. And so however big or small the scope of your outreach is, just please use this, and you'll be happy that you did. If you're going to send your resident abroad, you're going to have them travel. You got to prepare them. Here's the clinic we send ours to, with kind of the old-timey wards, the beds next to each other, and the mosquito nets, and here's a neonatal incubator. So it's going to be a very different environment than what they're accustomed to. So first things first, address the health and safety issues, make sure all vaccinations and prophylactic medications are taken care of. Some cultural and language training goes a long way. There's a ton of free apps out there for pretty much every language in the world, I believe. Just learn a few greetings. If you can greet a physician or a patient in their native tongue, that goes a long way to establishing some rapport. Obviously, the more complex medical decisions will require an interpreter, but just a few common phrases really does a lot. And then, I cannot stress this enough, but assess the current healthcare system and practice patterns. The needs really has to come from your partner institution. I'll give you one example. We thought it'd be really cool to do an ultrasound module of the shoulder. There's no MRI available at this clinic, so we'd help them diagnose labral pathology and rotator cuff tears, and we thought it'd be awesome. And they kind of shrugged their shoulders and said, there's no orthopedic surgeon here. We can't fix those problems. We have no need to diagnose them. So it's just a good lesson for us that we need to let them drive what they need. They need to tell us what they need, and that way we can produce some effective educational materials. Be very clear with your trainee. They're going to be traveling abroad. Make sure they know what their duties are. Night, weekend coverage, are they expected to be available? Are they allowed to kind of travel on their own? The travel logistics, how are they going to get to and from the clinic to wherever they're staying? And a packing list, just because, like I said, there's some things you're not going to be able to acquire once you get there. Plan your educational material, replan it, practice it. If you're going to be giving lectures, you really need to know the audiovisual capabilities, the form, and most importantly, the participants. Are you going to speak to practicing radiologists and radiology residents who are very imaging savvy, or are you going to speak to people with very limited experience to medical imaging? So you're going to make sure you have the appropriate level of sophistication in your materials. If you're going to do hands-on workshops, please do a trial run. Another example from our experience, we were going to do a vascular access lab with a gelatin ultrasound phantom. They told us that would be helpful for them when they couldn't get vascular access. So we had some little straws all laid out and ready to go to serve as our surrogate vessels. And we dumped the hot gelatin on them, and they just melted and made a big mess. And so we kind of were a little shaken. So we went and purchased peanuts at the local market and just buried those instead. And instead of a vascular access lab, now we're doing a biopsy lab, a nice shadowing peanut mass. So you have to be a little flexible, but if we had done a trial run beforehand, we could have been a little more prepared and saved ourselves some anxiety. I've kind of focused on the educational materials that your trainee or your faculty are going to deliver, but please realize this is a two-way exchange of information. Your trainee is going to gain a tremendous amount. They're going to encounter novel diseases and advanced presentation of disease. There's very advanced tibial osteomyelitis that happened due to an untreated overlying infection, very widely metastatic osteosarcoma, obviously very late presentation. The novel diseases, this is hepatic schistosomiasis with all the fat around. They sent me this I was in South Carolina, and they sent me this case, and thankfully I got to look up StatDX and kind of confirm it before I had to respond, because I had never seen this before. I didn't know what hepatic schistosomiasis looked like. But you gain some novel teaching material that you can now show to your trainees. Your trainee is going to learn to function in a limited resource environment. Where we send them, there's no CT available, so they can't recommend a CT after looking at the chest x-ray. They really have to fully evaluate that chest x-ray and come to a diagnosis. And they're going to gain a ton of teaching experience. It's very gratifying to watch. They really transition from learners to educators. They become a voice of authority, and they can really take control and deliver a lot of educational material, and that's great to see as faculty. And then they learn that cultural sensitivity. They interact with people from different cultures, different levels of medical literacy, just something that really can't be replicated here in this country. So in summary, as imagers, we are going to have increasing opportunities for global partnerships as imaging continues its spread to the developing world. If you're going to something you're enthusiastic about and you want to do, make sure you have buy-in from your faculty and your department chair. And there's a ton of potential partners out there, and that means the scope of your outreach can vary tremendously. There's tertiary hospitals with cross-sectional imaging and fully functioning training programs like the EMRI program, all the way down to clinics with no trained medical imagers like where we send our residents, and everything in between. So plan the scope of your outreach, prepare your trainees, and our specialty just lends itself to data sharing, so if you leverage that, you really expand your impact. Thank you, guys. I welcome any questions at the end.
Thank you, Dr. Stalcup. Our next speaker, Dr. James Anderson, you already know him. He gave a great review, and he's our RC chair. He's addressing standardization. Thank you.
All right. This feels like the opposite of what I just went through. So from something as exciting as global health to as exciting as standardization. And this is also kind of the opposite in the few slides, lots of talk. So standardization, I'll talk a little bit about pros and cons. We'll talk about forms, curricula, and interviews. I'm going to concentrate mostly on interviews because that's what a lot of people are trying to do, is trying to standardize interviews a little bit. So there's actually a great resource. AAMC has best practices in conducting residency program interviews. It's a really nice resource to review whether you're doing standard interviews or you're structuring your interviews in a new fashion. There's certainly a lot of data in here about how structured interviews can help and actually give you more information. We all know that interviews serve multiple purposes. I mean, part of it is to evaluate the person that you're going to potentially put on your rank list, but it also serves as a way to recruit people and to kind of screen out people that maybe aren't, and I know it's bad to say, but a bad fit, but maybe just don't fit in with your educational goals or objectives as a program, or potentially don't have the same learning style as what you can offer them, even if they're perfectly good candidates. So, those are other reasons to have a good structured interview. There's lots of different ways to structure an interview or standardize an interview. One good option is to at least have some standardized questions that you ask of all candidates. I know many from talking to my own residents and medical students that I advise and people that have gone through the process, I think the vast majority of radiology interviews are still just purely free-form conversations. That's the feedback I get most commonly, is that it's just a conversation and there's no real standard questions that are asked. There is definitely some value to having some standard questions so that you can assess one resident or one candidate compared to the other. The format of your interviews, so some people do a very, again, structured format where you go through and talk to a certain person for a certain length of time. Other places have a much more loose time format. The one thing I haven't heard much in radiology is any kind of rating scale for interviews. I haven't heard of very many places that actually use a standardized or even semi-standardized rating scale to judge your individual candidates. And that is also something that's been shown in a lot of research to make an improvement to the interview process. And the other thing you want to do when you're structuring your interview is the candidate perception. So because radiology largely does have this free form, very informal, everyone says they're so nice, the candidate perception, if you start to structure your interview, be aware that you can have actually a negative impact on how your program's perceived if you start to structure it. So just be aware of that potential negative impact that you can do if you start to over-structure your interview. This is some of the data from that AAMC publication, and it just shows about the reliability, validity, and fairness of different types of content or different types of evaluation that you can add into your interview. But also it shows that applicant reactions to that can be negative. So you have to be aware of those aspects. It is worth going through the process, because even if you don't ultimately change your format too dramatically, even a little bit of change can significantly improve your interview process. Back to the rating scales. So if you want to have a rating scale, you want to make sure that either an individual uses it uniformly, or if you're having multiple people use it, that they all understand how the rating scale works. There's some standard aspects that are in this publication as well about do's and don'ts. For evaluating your interview, you want to stay objective. Certain things you just can't ask, and those are all listed in this publication. Focus on the question at a time. So if you're using standardized questions, make sure you stay on topic for that question and don't let either the candidate or yourself get pulled off of that particular question or dimension that you're trying to assess. If you are going to use scales, Make sure they're anchored well, that you have good descriptors of each point on the rating scale. The big problems with people doing these type of interviews is the interviewers, especially if they're used to the free form process, will often fill in answers and coach the candidates as they're interviewing. And so if someone goes from a free form interview to a standardized interview, it's hard to get them to abide by kind of the rules of the different format. So anyway, I think every program, it's a good idea to evaluate interviews, evaluate what you're using it for. Some places don't actually want to rate the candidates so much on the interviews. They're just kind of screening them and recruiting them. If that's the purpose of your interview, then make sure your whole committee that's interviewing is aware of that aspect. If you're actually trying to truly evaluate the candidates and rate them compared to another, you might want to think about how you want to do that. The other aspect of being a program director are all the forms you have to fill out, and if you're a new program director, you'll be overwhelmed with the amount of different forms you might have to fill out. And if you're an existing program director, again, I kind of implore people to every once in a while review those and make sure that you're filling out the forms. They're updated, they meet requirements and things like that. There's a lot of internal GME paperwork as well as ACGME paperwork. But the bigger ones that you want to standardize are the things that you do frequently. So resident meetings, you want to have a standardized format for how you're going to write up each one of those meetings and make it efficient so that you can get through not only the process of talking to the resident, but how you write that up afterwards. And you want to have that as standardized as possible to make that a very efficient task. End of year evaluations, the final evaluation that you give, you want to have a very standardized form for that so it's uniform year to year from resident to resident. It makes it much more efficient. You can still free form some of the information, but you definitely want to have that as standardized as possible. And for anyone that's had to look back at old residency information to verify training of someone, and I've done that for people that have been out of training 30, 40 years, and their file is literally that thick. And they have 3 pieces of paper in their file that says they were hired and they finished. And that's it. And it's hard to evaluate. So you don't want to have the future program director be in that situation. You want to provide enough information that a future program director can look back at your documentation and they can understand it and they can know a little bit about who that resident was and what they did while they were at your program. Your educational program is another aspect of standardization. You want your goals and objectives to be standardized. You don't want each different rotation having a completely different format for those. So you want to go through your program and standardize all of that. Obviously, your PLAs, usually your GME office requires that those are standardized, but again, a very standardized format. But then your CCC and your PEC documentation makes it much easier, much more efficient if you have a standardized form that you fill out for those 2 processes so that each year you can fill that out in a unified form and you can look back at the last year's and take goals and objectives that you had from the previous year and move those on to your new year. If you're doing that just free form, you're wasting a lot of time and you're not being very efficient about your process. So you want to make sure that you get those as standardized as possible. So I'm a big one that is very much feel that residents should be treated as individuals, and depending on the size of your program, that's easier or harder to do. So there are definitely pros and cons to standardization. I think forms, processes, all excellent things to standardize. But when it comes to your individual residents, as much as possible, you want to try to treat them as individuals and original human beings and tailor their educational experience to what they need. And as Cory was saying, you know, different residents need different types of educational experiences. Some may need a learning specialist. Some may need different types of training. You've got to have some flexibility in your program to allow for that. That isn't an argument against standardization, but those 2 things can be compatible. What you do want to do is whenever you make exceptions to standardized process, you want to document why that is, because what you don't want is you made an exception for this resident to give them accommodations, to change their schedule, to give them a learning specialist, and then another resident says, well, why don't I get that? And if you don't have it well documented and standardized as to why this resident is an individual and unique, you can't really stand there and argue against the other resident when that person comes up and talks to you. So standardization also protects you in the event that you need to individualize training in any fashion. So good documentation on anything you change from your standard process is an excellent idea. I think that's it. I think I did it on time. All right.
Thank you, Dr. Anderson. Our last speaker, Dr. Christopher Ho. He's an assistant professor of radiology at Emory, program director of DR, and associate program director of the IR residency program. He'll address social media and informatics. Where are you?
All right, good afternoon, everyone. Thank you to the APDR, Dr. Mullins, Dr. Bueno, and Dr. Ruchman for giving me the very easy task of talking to you about social media and informatics in 10 minutes or less. So, but I'll leave time for plenty of questions at the end. But no financial disclosures. Again, thanks to everyone for staying for the late session. So this is how you sign up for Twitter. You go to Twitter. Okay, I'm just kidding. I just wanted to make sure, see if anyone would walk out. But okay, this is not what we're going to talk about. There's plenty of resources out there. But what I'm going to talk about are different social media platforms that are useful for educators and program directors. Why we should even care about it as educators in radiology. And then we'll talk about specific uses that we can use it for. And I'll give a little bit of informatics update also. Just so you know, if you just look at JACR, type in social media in the search bar, and and you can search by year. From 2015 to 2017, you see a 260% increase in social media tags in JACR. From 2016 to 2017, a 200% increase. And again, 2018 is on track to be just as high again as 2017. So again, it's popular, and I think as radiologists who very much focus on technology-driven resources, this is kind of our field. So there's tons of platforms out there. It really depends. Here's a list of them. I'm sure there's even more, but again, really depends on what your goal is. Who is your audience? What are you trying to reach? What is your final goal? Are you trying to show them a procedure? Are you trying to disseminate knowledge? Are you trying to just advertise something? So it just really depends on your comfort level and what your knowledge base is and what your ultimate message is in terms of what to pick. For the purpose of this talk, I'll focus on Twitter a little bit more. But again, I get to give this talk a lot of credit to my colleagues, and give the talk itself, I get to brag a lot about my colleagues a lot, so I'm kind of happy about that. But I adapted part of this as a top 10 list from some of my colleagues that recently gave a social media talk to our medical school. I didn't use all the 10 things, but I'm just going to adapt a couple of them that I think are useful for us as educators and program directors. But social media can be really powerful tool for advocacy. And whether it's reaching your patients, reaching your referring physicians, or your colleagues, it's an easy way to reach a lot of people. And I can brag, this is one of our fellows, Chris McAdams, who's going to stay on with us, the staff, advertising for and advocating for a tweet chat talking about diversity and recommendations for screening breast cancer in minority patients. Social media is also a very, very powerful tool to build your brand. You as physicians should be marketing yourself and marketing your interests and marketing your goals. I don't know Dr. Kat personally, but if you are interested in anti-aging skincare and financial freedom, maybe you want to follow her. Again, she is very good at building her brand, and that's what we got to do as radiologists, right? Education, another huge piece of social media can be used as. Again, I can also brag about one of my associate program directors, Dr. Peterson, who handles our Emory case of the day. This allows wide dissemination of knowledge very quickly, very easily, reaches a large audience, not just only our own residents, but residents, trainees, medical students, other radiologists across the country that are interested in learning, and this is a very easy way to do that. So why care, right? Like I said, obviously earlier, you can reach a much larger audience, beyond your region, beyond your institution, very quickly, very easily. In terms of networking and collaboration, this is kind of what it's all about. There are plenty of people I have met through social media or some sort of networking. And collaborate with them on projects. I've never even physically met them in person until an AR meeting or some other meeting, but great opportunity for that. And it's really easy access, right? Anyone can do it. Anyone with a computer, even a 400-pound guy sitting in his bed could do it, right? If you remember from the presidential debates. So anyone can do it. Anyone has access. And really, as educators, you should use it to promote yourself, right? Not just what you do and what you're interested in, but hey, did you write a paper and it published? Hey, shout it out to the world. Not everyone maybe read JACR that month or academic radiology, but that gives you a chance to promote everything that you're doing and all the great things you're doing as educators. So again, kind of just reiterating, but as educators, right, how can we use social media? You can really speak to your audience. Here's an upcoming event, here's a tweet chat, here's an interesting case. Again, knowledge dissemination, and it's there. It's easy. Everyone can access it anytime they want. You don't have to come physically to a forum or to a class. It's easily accessible from anywhere. And to speak a little bit more specifically to the program directors or associate and assistant program directors in the audience, it's a great way, I think, for myself to really advertise how great your programs are and how great your initiatives are. So you can just kind of see, this is my Twitter splash page, homepage. But I want to highlight everything that our residents are doing because they are the heart and soul of the program. Here's just these are all of our graduating fourth years, but I use it really as a tool to advertise what we're doing, what educational initiatives are happening, and I try to kind of keep it clean and not too filled with too many things here. But I think it's a powerful, powerful recruitment tool. Medical students, applicants are very, very savvy. And as you know, when you meet them, they've read your web page probably about 30 times. They know exactly what your last paper published was. They know what you're working on, and they'll do the same with social media. They'll take a look at they'll just kind of lurk, and they won't follow you, but they'll lurk and see kind of what you're doing on Twitter, what you're doing on Facebook. And I think it's great. It's a potential outreach for you to reach those students, again, because they're very, very tech savvy. And I use it a lot, too, to talk about resident life and our accolades. Our residents are doing so many amazing things that I want to tell everyone I can, and not just people at our institution, but everywhere else. Now, is it ready for prime time to replace traditional communication methods? For my purposes, probably not. I still rely on email for things, but again, it can be used, I think, very strongly as an adjunct communication method. And like I said, advertise, right? All of you are doing so many amazing things out there, and use this as a tool, right? We can use it to advertise our applicants that matched with us. We can use it to announce our residents that win national awards at meetings. This is one of our residents, Christopher Hesch, winning the SIR case competition, which the IR folks apparently tell me is a very, very big deal, so we're very happy about that. Again, I don't own any plant-based anti-aging remedies, so I can't advertise that, nor Emory would probably want me to advertise that, but I can advertise my residents and the great things that we're doing at the program. So again, switching gears a little bit, we'll talk a little bit of kind of informatics update. When I hear the word informatics or IS or IT, some of you all may remember when Homer Simpson was trying to start a business, he said, what can I call this business? CompuGlobal Hyper Meganet. Yes, let's just put all the buzzwords together and call it that. And that's what I think of when I think of informatics sometimes, because I think it's a very, again, for myself, I'm not an informatics guru, but it can be a very nebulous term. But really, if you think about it, informatics is the principle of using information and computer science to really advance what we're doing both in the public health sector, patient care, education-related matters, and radiology is really about big data. There's so much data in what we do. Anytime you open a study, start dictating, close it, all these things are tagged in some manner. So really, this is, I think, the future of radiology in terms of research avenues. So there's plenty of opportunity there. And again, this should not only extend to us, but to our trainees. And if we look at it, too, there's actually been, if you look at the Society of Imaging Informatics in Medicine's website, SIM, there are currently 8 informatics fellowships dedicated for radiology across the country. And I can imagine probably, they didn't list when they started, but probably 10, 15 years ago, there was maybe 1 or none. But again, it's a very hot field, and again, I think we should be exposing our residents to this also. Again, I can brag some more about our residents here. Dr. Patty Balthasar recently won one of our internal grants and is developing an informatics track for our residents. So again, early exposure to informatics with kind of specialized teaching, small groups, capstone projects to really, again, kind of have this as part of the curriculum for those that are interested. And I think Dr. Heller talked to him a little bit about this yesterday. If you haven't heard, there is now a national imaging informatics course that runs twice a year, once in the fall and once in the winter. They're 1-week courses. They're geared towards your 4th-year residents. And they are both online classes, small group discussions with a little bit of homework. The residents are expected to be there the whole week. Because of time differences, the East Coast residents start at 12 o'clock till about 5 o'clock in the morning. They work on their projects and their homework, and then, so they can catch up with the West Coast time. But it's kind of sponsored in conjunction with RSNA and SIM, and it's just another great opportunity for our residents. Right, it's a $500 course, not per residence, per program. I will give the disclaimer that I didn't participate in developing this, but one of our faculty members did, and this was the Vice Chair of Informatics. And again, this is just another great opportunity for another tool for the residents to put in their bag. And Dr. Anderson, cover your earmuffs on. I know this isn't a requirement of Milestones or ACGME yet, but again, it's a great opportunity for them to learn something else that will be very valuable to them in the future. So in conclusion, don't be afraid. I think that's the main thing here. I was very resistant to Twitter in the beginning or some of these social media things. I just kind of lurk and wouldn't really post things. But again, they're powerful tools, easily accessible. If you just kind of logged into Twitter now at AER and looked at the AER 18 tag, I mean, there's just hundreds and hundreds of tweets going on just the last 3 days. And really allows you to expand your reach beyond your institution and reach a larger audience of not just your educators and trainees, but your patients too, depending on your interest. So thank you.